In this episode, we will discuss polycystic ovarian syndrome. Even though I'm trying my best to stay away from basic science and molecular pathology discussion and dedicate these episodes mainly to clinical diagnosis and workup, a basic understanding of pathophysiology would essentially help every aspect of clinical decision making, from the understanding of the clinical symptoms to understanding of the rationale behind labs to order and the treatment options. So the first question is, what is the exact pathophysiologic events in the course of polycystic ovarian syndrome? The first event is insulin resistance for any reason. That's either idiopathic or obesity, etc., which translates into hyperinsulinism. Remember, hyperinsulinism means decreased binding globulins, including sex hormone binding globulin. And when we have decreased levels of sex hormone binding globulin, we will have increased levels of free androgens. And I cannot emphasize enough on the word free, because the total testosterone level is not necessarily changed, but the free androgens, free testosterone level is increased. Now, free testosterone by the enzyme aromatase gets converted to estrone. So we have increased level of estrogens also. Now, estrogens would suppress gonadotropin releasing hormones, and as a result there will be suppressed level of gonadotropins. Again, I'm talking about absolute value of both LH and FSH, not discussing their ratio. And because of dropped values of gonadotropins, we will have no ovulation or decreased ovulation, that is oligoovulation or anovulation. Because of no ovulation, the corpus luteum is not formed, and therefore we will have no progesterone. Low progesterone with increased levels of estrogen translates into risk of endometrial hyperplasia and the following complications of hyperestrogenism, including endometrial and breast cancer. So based on this understanding, let us discuss the possible lab formula of polycystic ovarian syndrome. What is it? We have increased levels of circulating free androgens despite decreased levels of sex hormone binding globulins. This may translate into normal values of total androgens for the female patient. This also means increased estrogens. We also have suppressed GnRH and gonadotropins absolute values, but we have increased LH to FSH ratio. Because of suppressed gonadotropins and absence of LH surge, we also have no ovulation, and therefore we have low progesterone. The metabolic test can also show impaired oral glucose tolerance test. What is the requirement for the diagnosis, exact diagnostic criteria? Well, we have the old school diagnostic criteria of NIH, and we have the Androgen Access Society's 2008 diagnostic criteria, but the most commonly used criteria is the 2003 Rotterdam criteria. The Rotterdam criteria requires only 2 of the 3 cardinal symptoms to be present. What are those? Oligo or anovulation as manifested by amenorrhea or heavy or irregular menstrual bleed. Clinical or lab evidence for hyperandrogenism. Again, pay attention to the fact that we said clinical or lab. And finally, presence of multiple cysts on ovaries by ultrasound assessment. Now, one difference that Androgen Access Society criteria has is that causes of hyperandrogenism should be ruled out. That's other causes. And also ovarian dysfunction is umbrellaed under one criteria, and that is either oligoanovulation symptoms or polycystic ovaries. This is in some ways also similar to the NIH consensus criteria, that everything is required and the other causes of hyperandrogenism should be ruled out. True or false? Symptoms or lab findings confirming insulin resistance or diabetes is part of the required criteria for the diagnosis of polycystic ovarian syndrome. That is false. Even though we mentioned that the core pathophysiologic event at the very first step is insulin resistance, presence of lab or clinical findings in support of insulin resistance is not part of the standard criteria requirement of the diagnosis. Again, based on the pathophysiologic pathway we discussed, what are the possible clinical findings? You should probably know all of them by now, given the pathophysiologic discussion and the criteria discussion. So we have obesity, we have infertility, we have symptoms of hyperandrogenism, including acne, hirsutism, and male pattern baldness, the androgenic alopecia, and the metabolic findings, including diabetes, especially type 2 diabetes, which is insulin resistance, and syndrome X, the metabolic syndrome. You know, the syndrome that's equivalent of coronary artery disease, as it presents extremely high risk of acute coronary syndrome and is associated with hypertension, insulin resistance, central obesity, dyslipidemia, and is associated also with non-alcoholic fatty liver disease. Now, you may be asked about the complications of the polycystic ovarian syndrome. Remember, those are the complications of perhaps obesity, such as obstructive sleep apnea, or, as I mentioned, non-alcoholic steatohepatitis, or it could be complications in association with unopposed estrogen excess, such as endometrial hyperplasia or cancer or breast cancer. True or false? Patients with polycystic ovarian syndrome could be virilized. That's false. They have hirsutism, that is excess hair or possibility of acne and androgenic alopecia, but they are not virilized. For example, they do not have excess muscle growth or clitoromegaly, or necessarily deepening of the voice. Now, true or false, simple facial acne is a sign of hirsutism? That's not true. The acne that is seen in polycystic ovarian syndrome, or is more reflective of hirsutism, is the severe nodulocystic acne that appears on the torso and back. Why knowledge of this differentiation is important? Because if a woman just has simple acne, not the nodulocystic acne, you cannot use that simple facial acne as an evidence of hirsutism and build the criteria for polycystic ovarian. Again, the understanding of pathophysiology helps us understand the differential diagnosis and the rationale behind ordering the diagnostic workup, evaluation, and tests. What are the major group of differential diagnosis and therefore the major group of tests and workup? Well, we have the differentials of hyperandrogenism, such as the adrenal pathologies like Cushing or congenital adrenal hyperplasia, especially the non-classic type 21 hydroxylase deficiency. Then we have the differentials of amenorrhea, and then we have the differentials for metabolic changes that are seen in polycystic ovarian syndrome. Can you list some of the important or top differential diagnoses of PCOS? Well, as I mentioned, the other cause of hirsutism, such as congenital adrenal hyperplasia or Cushing, but also include the androgen-secreting ovarian tumors and ovarian hypertrichosis. Then we have other causes of amenorrhea such as pregnancy, hyperprolactinemia, and thyroid disorders. And then we have metabolic changes independent of PCOS, such as type 2 diabetes, syndrome X, not in the setting of polycystic ovarian syndrome, etc. Based on this knowledge of differential diagnosis, what is the very first set of tests we need to order? And you need to follow this hierarchy. The first assessment is assessment of free testosterone, especially together with sex hormone binding globulin level. Most of the current guidelines recommend that these two be ordered together. Then we order the test for the most common type of congenital adrenal hyperplasia, and that is 17-hydroxyprogesterone level. And then we test the standard panel for assessment of secondary amenorrhea, beginning with beta HCG, then including TSH and prolactin. Now, there is a very important point here that even though the initial workup is the tests that I mentioned, there is a possibility that the clinical picture argues in favor of androgen excess, and we may not in that situation need to order testosterone measurements. The other emphasis on the basis of clinical diagnosis is the fact that if initial tests have fulfilled at least 2 of the 3 criteria without need for ultrasound, we do not perform ultrasound to confirm the diagnosis. Okay, so a woman simply has amenorrhea or heavy menstrual bleed or irregular menstrual bleed in favor of anovulation or oligo-ovulation, and then this woman also has symptoms of, let's say, nodular cystic acne or androgenic alopecia. She already meets 2 of the criteria without the need for any labs. She is diagnosed as PCOS. Now, the next question is, what are the tests to be performed in a woman with the diagnosis of PCOS? So, please differentiate between the fact that we do not need to necessarily or 100% rely on the lab workup for the diagnosis, but we still need to order almost all of the tests to rule out the possible alternative diagnosis. We need to order the adrenal test to rule out the possible alternatives for androgen excess. We still need to perform transvaginal ultrasound in a step after the diagnosis is made, if the diagnosis is already made, or before that if needed for building the diagnostic criteria, to rule out the possibility of ovarian tumor secreting androgen, and so forth, so on. So always have this in mind, that how we built the 3 required components of the diagnostic theory is different from what we perform as lab assessment for ruling out the alternatives. Another tricky point is if the testosterone levels are normal, what we deal with this. Again, let the clinical picture guide you, regardless of the levels of even free testosterone. If the patient has symptoms of hirsutism, the hyperandrogenism criteria is fulfilled. Why the testosterone levels could be normal? Well, testosterone levels could fluctuate with the fluctuations in sex hormone binding globulins, and I'm talking about free testosterone, or the total testosterone is normal because of the fact that free testosterone is high, sex hormone binding globulins are low. So, as I'm saying again, don't rely 100% on one test. Another issue in the assessment of free testosterone that makes it less reliable is that the immunogenic tests, that's immunoassays, are not the most reliable methods for assessment of free testosterone. We prefer chromatography with mass spectrometry as the most sensitive test for assessment of free testosterone level. Now, I think I clearly mentioned that we still order the secondary tests, right? even though we may not necessarily depend on them for building the diagnostic criteria, we still need to order them. What are the example of those secondary tests? In addition to performing transvaginal ultrasound, even if it is not necessarily needed, if the diagnostic is already built otherwise, to rule out the ovarian androgen secreting tumors, we need to also perform the test for adrenal androgen excess. And what is that test? That's dihydroandrosterone sulfate test, DHEAS, dihydroepiandrosterone sulfate. Then also we need to assess Cushing and congenital adrenal hyperplasia, as I mentioned. Even though 17-hydroxyprogesterone is one of the initial tests, the test for Cushing is indicated only if the patient has symptoms in favor of that, and so the test is 24-hour free cortisol, 24-hour urine-free cortisol. Is there an alternative for this test? Yes, low-dose dexamethasone suppression test could be an alternative for assessment of possibility of Cushing. What are the tests for assessment of the metabolic status? Again, 2-hour oral glucose tolerance test, the screening test for diabetes, as well as fasting lipid profile, including the lipoprotein assay. Now, what is the finding in PCOS ultrasound? It is referred to as the pearl necklace sign. And what is it? At least 11 small subcapsular follicles identified in each one of the ovaries. Again, remember, this is not mandatory for the diagnosis if the other criteria are present. Many references mention that only a majority, up to 70% of the women with PCOS meet this ultrasound criteria requirement. True or false? Levels and ratio of gonadotropins is required for the diagnosis of PCOS. That is false. Even though it is not required yet, we still perform that, and we have the absolute levels suppressed because of excess estrogen, but we have increased LH to FSH ratio. Even though I would discuss the differential diagnosis of obstetric endocrinology in different episodes, I cannot convince myself not to ask this question here. What is a means of differentiating clinically the androgen secreting tumors, either from ovary or adrenals, from PCOS? Always remember that in the androgen secreting tumors, we have rapid onset hyperandrogenisms plus virilization. And by rapid onset, I mean presence of extremely excessive androgen, which causes virilization in less than 1 year. PCOS has slower pace and lower quantitative levels of androgens that causes hirsutism but does not cause virilization. How we know also that we are dealing with PCOS as the cause of amenorrhea or any other cause of amenorrhea. Any other cause of amenorrhea than PCOS and some of the hyperandrogenism syndromes are not associated with hyperandrogenic symptoms. And I'm talking about the top of the list: hyperprolactinemia, thyroid disorders, and pregnancy, as well as the functional hypothalamic amenorrhea. None of those are associated with hyperandrogenic symptoms. Okay, now let's discuss the essential components of the treatment for the PCOS. We categorize, or let's say I categorize, the management and treatment of PCOS into essential management and then symptom-based management or symptomatic treatments. Now, in the course of essential management, we have a couple foundational questions. And what are they? One is the very first treatment recommended for all patients with PCOS. What is that? That's weight loss. Remember, in the very first sentence of this episode, I mentioned the problem begins with insulin resistance and obesity. So again, the treatment in all patients begins with weight loss, weight reduction. Now, what are the other components of essential treatment? That's the treatment that addresses the core pathophysiology. One is addressing the insulin resistance with metformin and then considering the next step management for the hormonal imbalance that we have with regard to whether or not the patient desires to conceive, desires future fertility or not. So weight loss and metformin for all patients, but if the patient desires to conceive, what is the treatment recommendation? Either an aromatase inhibitor like letrozole or a selective estrogen receptor modulator like clomiphene. Now, which one of these two is preferred? Letrozole is preferred to clomiphene. How does these medications work? Well, letrozole inhibits peripheral conversion of excess androgens to estrone, and therefore it disinhibits the gonadotropins, and therefore the system starts working, and the anovulation and everything distal to that will be corrected. Now, if the woman does not want to conceive, what is the treatment? That's OCP. What type of OCP is recommended? Combined oral contraceptive pills. Why is it so? Because specifically we need that progesterone component, and that is to enable ourselves to counterbalance the estrogen excess. So if for any reason the patient cannot take combined oral contraceptives, what's the recommendation? Progesterone only pills. And that's again for the patients who don't want to conceive. And finally, we are going to discuss this symptom-based treatment or symptomatic treatment. What is recommended for hirsutism? Both combined oral contraceptive pills and metformin, or anti-androgens such as what? Such as spironolactone or finasteride. What's recommended for obesity? Diet and exercise. Now again, I want to once more emphasize on the understanding of pathophysiology when you want to associate any of these treatments with any of the findings. So take this true or false question. True or false, we use oral contraceptive pills in PCOS to address anovulation and amenorrhea. That is false. You know that OCPs themselves cause prevention of normal menses in the women without PCOS. So we do not use them for treatment of anovulation or amenorrhea, even though we can use them cyclically. So what is the main rationale for use of OCPs? As usual, for contraception, as we mentioned, in women who do not wish to conceive. The second rationale is the endometrial protection because of the progesterone component. And third rationale for use of OCPs, thanks to the estrogenic compound of it, is that it can address some of the hyperandrogenic findings, such as especially the severe acne, which is due to excess androgens. So how do we manage the anovulation and amenorrhea in PCOS? Again, if you start with the pathophysiology, the very first step is to address excess weight. The next step is medical management, beginning with letrozole, and then after that the alternative is clomiphene. Some references may mention both of them are a good candidate as first-line management. Never pick FSH injection as the first-line management. If no other means, including letrozole or clomiphene, is available, we may consider FSH injection for the management of anovulation. And always remember, metformin almost addresses everything. So why most of the references talk about metformin as an adjunct treatment? Even though metformin can address the core and the very proximal step of the pathophysiology, because it fails to address the risk of the endometrial hyperplasia complication, and because it does not directly address symptomatically the hyperandrogenic symptoms, it is not necessarily the first-line treatment. But again, as I mentioned, it is recommended for all patients, whether or not they want to conceive or want to have contraceptive methods used. Metformin has all the benefits, and this gives a very interesting understanding of the statistical or pathophysiological understanding as opposed to clinical significance. So even though metformin addresses the pathophysiology, from a clinical perspective, because we could have other medications combined addressing everything, including the hyperandrogenic issues and including endometrial hyperplasia, we may not necessarily include metformin in all the regimens if the patient is already responding to the other treatments. The rationale is to always pay attention to what individual patient needs. Some patients, for example, may have renal issues with metformin. Some patients may have weight issues with metformin, etc. I want to finish this episode with a case. We have a woman who meets the criteria of PCOS, who does not wish to conceive and have any future pregnancies. What is the very next step in the assessment of this patient? Well, given the fact that this patient does not want to conceive and therefore she goes to the category of those treated with OCP, not with ovulation induction methods, OCP initiation requires ruling out pregnancy. So all patients initiating any type of OCP require a beta HCG assessment to rule out pregnancy. And this finishes our discussion of polycystic ovarian syndrome.